about today, how can mental health care be reorganized and strengthened to meet reality, both in crisis preparedness and as a development priority? Just come forward to those of you who are coming late. There's a few seats here in the front as well. Mental health has been overlooked, both in development programs and the humanitarian response, for far too long. The key statistics are clear. WHO estimates that close to 1 billion people live with some kind of mental health challenge, and almost 3 million deaths annually due to alcohol and substance abuse is happening. Every 40 seconds, there is a person that chooses to end his or her life. At the same time, more than 75% do not have access to care and treatment. Non-communicable disease and mental health, neurological and substance abuse are on the rise everywhere, accounting for close to 80% of premature deaths globally. And mental health accounts for more than 10% of the global disease burden. The Lancet Global Burden of Disease study reported that among those between 10 and 24 years old, self-harm, depression, anxiety, and interpersonal violence are among the overall top 10 causes of death and disease. Add stigma, discrimination, and human rights abuse, and it is strikingly evident that we are facing massive challenges and increased action is long overdue. We have been discussing the many challenges of nexus, triple nexus, bridging the gap for many years. How can we facilitate for and merge investments in development and humanitarian assistance for a better impact and use of funds? Likewise, we have been discussing weak health systems, access to care, and integrated primary healthcare services for decades. Today, we will hear from some of the leading actors that are working to close these gaps and ensure strengthening of mental health response and care across the development and humanitarian field. Let me just briefly share some key points from the Norwegian priorities on this topic. Norway has mental, neurological, and substance use conditions high on our development agenda. And we are channeling support both through the multilateral partners like WHO and civil society, and we are happy that many of you are here today. We believe the best way forward is to strengthen health systems, build a competent health workforce, and integrate services in basic public health packages, and in line, of course, with the country needs and government priorities. We aim to contribute to strengthening of mental health care, prevention and treatment in primary healthcare, increase awareness and knowledge, and address and prevent human rights abuse, stigma, and discrimination, and prevent and reduce the rate of suicide. In our humanitarian strategy, support for life-saving basic health services is also an important element. This includes the needs to strengthen mental health services and psychosocial support. Mental health and psychological supports are also key to our humanitarian protection response. In a world of limited resources, it is obvious that we need to work better together to find new and innovative approaches for how to best solve and address these challenges. I'm just back from a visit to Nepal last week, where I was able to experience mental health programs firsthand. both from a prevention perspective as well as from a clinical treatment in hospitals and other institutions. You will hear more about the work in Nepal today from one of our panelists. But let me just briefly share some of my own reflections after visiting some of the programs in Nepal last week. The need for increased effort and priority was clearly evident. There are massive shortages to the services and the care needed in Nepal. In a country of 30 million people, a very limited number of professionals are educated and employed in the healthcare system and in the institutions. In most rural areas, hardly any services are available at all. And people in dire need of help need to travel very long distances to be able to get some help. And a lot of people are not able to do that. However, what was striking visiting Nepal, when we met the practitioners and the experts from the government, from civil society, from the multilateral actors, we saw dedicated people. People who have been able to realize very strong development with very limited resources. These engaged individuals are assembling the way ahead by showing that building step by step, using all available expertise from all different actors involved, working together, striving to scale every successful intervention, tirelessly working to mobilize more resources that are desperately needed. Change is possible. We need to scale what works. We must base our interventions and programs on evidence, but where numbers and facts are still missing, let's not overlook the importance of the many years of experience and lessons learned from each other. We need platforms to share those experiences and the knowledge. And also the promising and the best practices that we are aware of at this stage, but also the challenges that we all are facing. I hope this seminar will be such a platform to build, share knowledge and learning. Thank you so much to the speakers and the participants who are joining us today. The program, I think, is really, really amazing. And I wish you all a fruitful day full of learning. Let me introduce the moderator for today, Ragnhild Dybdahl. She has a very long title. She's the program director of the Norwegian Institute of Public Health, and she's an associate professor at the University of Bergen. Ragnhild, vær så god, please. Thank you.
Thank you very much, Lisa, for such a good introduction and to get us started this morning. It's a pleasure to be here, and also welcome to all of you from me and all of those joining us online. It's fantastic to notice such response for an event on global mental health. We have had to put out extra chairs. We had to open the room for more people than those that originally were planned for. And we see that there are participants from so many different organizations and institutions, which really is a strength, because if we are to make progress on mental health, we need everybody, because it concerns everybody. All people, all organizations, all institutions. No country has solved it. It's truly a global issue. And from the network, the Norwegian Network for Global Mental Health, we're very pleased that NORAD will host and collaborate on this event. And it goes to show the great collaboration between the network and NORAD, for which we're very grateful. Lisa made a very good case for the importance of mental health in terms of the challenges and the terrifying numbers that she presented. but this is also a challenge in terms of all the unmet needs. I sometimes think of it at the 90% field, because when it comes to mental health and health services, there's less than 10%, in fact, often seen as 2%, of the health budgets that go to mental health. Of people with mental health needs in low and middle income countries, it's less than 80%, or actually 90% in low income countries, who receive help. And so it continues. And of the small proportion of budgets that go to mental health, 90% or more go to 1 or 2 psychiatric hospitals in the urban centers. They go to the specialized services, which are important, but they're not sufficient. And therefore, we need some serious changes. And to discuss that, I'm very pleased that we have, as Lisa also said, a really strong presenters and panelists today. The event is streamed. Unfortunately, we will not be able to take questions on Facebook, but hopefully there will be time for some questions also from the audience, in addition to our very skilled panel. We titled this the Global Mental Health as Crisis Preparedness and Developmental Priority, because disasters, wars, natural disasters really are important aspects of mental health needs and also opportunities. At the same time, as we will shortly hear more about, for social and economic development, mental health and human resources are also crucial. And mental health really has, mental health interventions, mental health approaches, really has the potential to bridge this gap between humanitarian work and developmental work, because building stronger systems, health systems, building resilience is also preparedness. And I hope we will be able to discuss that today as well. We have most of the speakers online today. It is not only for environmental reasons, it's also because people are very busy working in ongoing developmental and humanitarian settings and are still taking time out to join us, for which we're very grateful. We were testing this morning and the technology here, and I think things were going really well. But then Michael Udedi from the Ministry of Health, who is online and will hopefully join, has been ordered to get in the car to go up to Blantyre in Malawi, where there's a horrific effects of the cyclone Freddy. We also have Ksenia Semeniak from Ukraine with us. But she also had to leave for a little while because Kiev had the alarm going this morning. And I was just saying to a colleague this earlier, sometimes I wish we were just working in Drammen because it's so much easier. But then it turns out it's not that easy in Drammen either. So we need to be together. I said developmental priority. And to kick that off, we're very pleased to have Harald Toru with us. He will give a presentation on the UNDP report from last year. Harald Toru has a very impressive list of merits, an amazing bio. We've put the bios out on the website. Maybe that's why you're all here, because you've seen these bios. He has worked with UNDP for many years, and the places and the work he's done is amazing. So, Harald, I know you don't have a PowerPoint, which means that we will see you and hear you and have to pay extra attention. And thank you very much for joining us. Please, the floor is yours.
Yes, good morning, everyone, and thank you so much for those very flattering words. I'd like to excuse myself not being there physically with you today. I'm in Copenhagen, unfortunately, but usually based in Oslo. But I'd just like to start by thanking Nora and the Norwegian Network on Global Mental Health for convening this very important seminar, and also for inviting UNDP and myself to be here today. Just to start with, when it comes to mental health, this is not, let's say, a new area for the UN or UNDP. However, it's really in the latest Human Development Report, which I'll speak about now more in detail, where we're really highlighting some of the developments and challenges with mental health and how important it is, particularly for development and for us, of course, in the work on the sustainable development goals. Also wanted to say that for me personally, this is an area where I've had until recently very little experience, but less than 6 months ago also I lost my father to suicide. So this is also something that me personally now I'm becoming very invested in, and I'm therefore also kind of on a personal level very glad to be part of this conversation today. Just to tell you, so what I'll do, I'll just go through the report relatively quickly. It's not necessarily anything groundbreaking and new, but I think it's important with some of the numbers we come up with in this report. The report, which was the Human Development Report, known as Uncertain Times, Unsettled Lives, Shaping Our Future in a Transforming World, was launched in September 2022. That was a part of a series of reports, and that was the third one, and it kind of covered 2020 and 2021. And the outset of the report was quite clear. While we faced in the past many difficult times and potentially more difficult than today, today's challenges are more complex than ever before. We're living in very uncertain times with the COVID pandemic, the war in Ukraine, many other wars and regional conflicts, and climate and ecological disasters. What I think is kind of particularly important from the report, which is relevant to our discussion here today, is that the number of people experiencing stress has over the last number of years been increasing. There's also higher insecurity, which is driving more mistrust and more polarization in society. This is also the first time since the Human Development Report, since it was launched in 1991. This is the first time over the last 2-3 years now we're seeing a reversal in human development in a number of countries. We also see from the report that about 1 out of 8 people suffer from mental health disorder. That's 10% higher than what was measured a decade ago. So clearly uncertainty creates mental stress. We also see that in the beginning of the COVID-19 pandemic, global prevalence of depression and anxiety increased with more than 25%. In particular, was actually interesting enough increase more among women than men. Why is this important for the UN? I think it's relatively obvious that mental distress can hinder people from developing their full potential. And it's also crucial then for us as a development actor to prevent and mitigate mental distress as much and where as possible. When you go in the report, I'll just go through some of a bit more in detail. It looks at both how it impacts people in childhood and adult life, and also connects mental and physical health. And I think what's really important there is that measuring mental well-being is very challenging, of course, because the concept is much wider than mere absence of mental disorders. And as we know, not all people who suffer from mental distress develop mental disorders, and many people do not seek professional help due to stigma or to lack of access to mental health services, or sometimes the lack of insurance coverages. And the effect of mental health or mental well-being run through several channels. We have traumatizing events, physical illness, climate and eco-anxiety, could be related to food insecurity, biodiversity loss, and many others. So this is some of the key factors that the report looks at. One which we have been looking more in detail in UNDP here in the Nordics is the aspects of digitalization. Digitalization, of course, comes with many positive aspects. It can improve lives, it can facilitate many processes, increase efficiency. It's the reason why we can have this conversation with people all over the world today. So it can really be positive in the sense of accelerating the achievement of the Sustainable Development Goals. At the same time, it comes with a number of challenges. It comes with, one of the very important ones is digital inequality. Poor people and those with existing mental health disorders can have a higher probability of being excluded. You have Facebook, Instagram, Twitter, where you often can see bullying and sharing of violent content. You also see mental distress and obsessive use of digital technologies. And we also see that obsessive smartphone use can result in chronic sleep deprivation and undermine cognitive and social and emotional functioning. So there's many aspects which are very challenging also with digitalization. We also know that mental stressors don't act in a vacuum, so it's also very, very interconnected, something the report looks at, and many reinforce each other, particularly in this context uncertainty as we're living through today. At the same time, we also know that multiple systemic factors can also help build resilience. So on resilience, one aspect that the UN looks at very closely is a particular work in peace building context. And I'll just quote the UN Secretary General, who says that peace building, mental health, and psychosocial support are deeply interconnected. People who have suffered losses, attacks, family separations, and gender-based violence carry grievances and wounds that can perpetuate the repetition and cycles of violence. When it comes to the work of the UN, this is, as mentioned but this is something we've been doing for years through a number of programs, but it's particular now, I think we're, with this report and with a lot of the facts on the table, I think we're seeing much more scale up across the world. As mentioned, we will have a colleague later speaking about Ukraine, so I'm not going to speak much in detail about that, but just to mention that already before the war, the full-scale invasion in February 2022, UNDP was working with post-traumatic stress disorder among ex-combatants. We also did with the CPD, cognitive processing therapy, working with mental health professionals in a number of parts of the country. And following the onset of the full-scale war, psychological assistance has been at the forefront of the response from the UN system, and it's something which is a big priority. But of course, due to hostilities, due to also a number of places support not being available or not physically able to get people there, it's still a huge challenge. So we're also there working with the Ministry of Digital Transformation, a number of ministries of trying to provide as much support as possible. Also in places like Kyrgyzstan and Colombia, a number of other countries, we've been working particularly with the reintegration of or repatriation of men, women, children who's been part of violent groups or guerrilla groups, etc., and trying to support them with their transformation back into society. Finally, I'll make my remarks relatively short so we can have more time for discussion. I just wanted to say that in 2022, we also launched a report, or a guidance note on integrating mental health and psychosocial support into peace building. And the key takeaways from that report are as follows. There's not one size fits all step-by-step approach on the integration of mental health and psychosocial support into peace building. We have to really look at it as mentioned in each individual case. It's extremely important to address and acknowledge stigma. And finally, organizations must acknowledge, manage, and support the well-being of staff working and living in contexts affected by violent conflict. So this report now, which is also being incorporated in a lot of the programs that we are working on. So with that, I would like to end my short remarks, and I'm looking forward to having questions and discussion as we continue. Thank you.
Thank you very much, Harald, for this very inspiring overview, and thank you for your commitment and for sharing your personal story as well. It is, and we are sorry for your loss and grateful for your commitment. And what you say also illustrates that mental health concerns everyone, not just on a professional level, but also on a personal level, because there is no one who has not, in one way or another, known someone or been affected by mental health challenges throughout life. You mentioned so many important issues from the report. The World Mental Health Report last year outlined 3 reasons for investing in mental health: public health, human rights, and economic development. You touched on all 3 of these, and I'm also grateful that you raised the issue of peace, which is often talked about among people who are working on peace, but perhaps less from mental health personnel. So very glad that you brought that up. We have time for one question from the audience, if anyone would like, and from the panel, if you're already keen to get going. If we have a question or a comment from the audience, we could do that now. And we have Jimmy. Well, please introduce yourself, and you will get a microphone.
Hello. So thank you very much, Harald. My name is Jimmy Westerheim, so I'm the founder of the Human Aspect. So my question was, you mentioned stigma as one of the key elements in this, which has been recognized, I guess, by most at this point. So I was wondering if you had some thoughts about how your strategy is surrounding on how to deal with that in this context from your side.
Yes, no, thanks very much for that question. I don't think it's a simple solution, but I think it goes back to being open about it. I think it's as in something, I mean, personally, by being open about my own situation, about many of our colleagues, particularly working in different contexts, have experienced or are experiencing mental stress, or have had people in their family affected by one way or another. And I think one way of doing it is really for the UN itself or in international organizations to, number one, speak openly about it internally, like where we were being and opening up, and in a sense of ensuring that it's okay. This is because I think if you often go back not many years, I think that because of stigma, I think people were there was definitely some concern that if you were affected by any type of mental health issues, that could impact your job or the way you were being perceived or your career ambitions. I think by having much more openness, that this is something we can, we need to take seriously, and will not, necessarily impact anything of how your career goes. I think that makes it much more, okay in a sense of being discussed. And I think, of course, but as mentioned in some of the, and when many here have much more experience, but obviously in some contexts we're working, suicide or mental stress, like mental disorders are really stigmatized from the highest level, from government up. So it's also important for us as international actors and development organizations to bring up those conversations and come with programs that kind of have a local approach and fits to the context. But I think by providing these type of reports, by providing evidence, this is hopefully something, and also showcasing how common it is and how many people are impacted by it. This will hopefully also lead to more political will behind dealing with it. So sorry for this a bit convoluted answer, but I think that's our main approach at the moment.
Thank you very much. Thank you for that good question and for reflecting on that, Harald. And you also really brought up the human rights aspects, and both now and during your presentation. So I really want to thank you for that too. Is there one more question? If not, then we will have time also after the 3 presenters for, hopefully, if everyone is as structured as you are, Harald, then we will have 15 minutes for discussion. Thank you again very much. And because you mentioned peace, I would like to end your session and bridge to the next by quoting from the UNESCO statutes, where it says that because war starts in the minds of men, it's in the minds of men that peace must start. So the UNESCO has really started their reason for being linked to peace and the minds of men, or mankind. The next speaker I'm also very happy to introduce you to is Dr. Alison Schaefer from the WHO. Thank you very much for joining, Alison. I know you're in Nepal at the moment. Alison's bio is also on our website, again, long and impressive. And you are in charge of the Special Initiative for Mental Health by WHO, which is a very interesting and important initiative. And we look forward to hearing how that is going and how it linked to the main topic of today of what can we do, how can we do things differently. Thank you very much for joining, Alison. Screen is yours.
Thank you so much, and thank you everybody for having me here today. I did actually prepare a PowerPoint presentation which I'll share for you, and I can see that's coming up on your screen now. Okay. So it's a pleasure to speak with you today about our WHO Special Initiative for Mental Health. This here is an image from a cross-country meeting we had in Istanbul last month, and it just shows some of the incredible people we're working with on this initiative. Just trying to go to the next slide. There it is. Okay. So we've already heard from our initial speakers that there are many areas of mental health work that's needed in the world. And we've heard some of the daunting statistics around the lack of access to services and the massive treatment gap. So WHO's Special Initiative for Mental Health is specifically aiming to try and reduce that treatment gap, which is seen in most low resource settings. We're targeting mental health policies, rights and laws, and the scale up of services, especially scaling up at the primary healthcare levels. Key to this approach is a commitment by WHO and ministries of health to actually work together for a minimum of 5 years to truly start instituting some systems level changes. The Special Initiative for Mental Health was officially launched in 2009, and in 2020 we received some financial support and began work in 6 countries. We started off in Bangladesh, Jordan, Paraguay, the Philippines, Ukraine, and Zimbabwe. By 2021, we received additional support to the initiative and were able to expand to Ghana and Nepal. And last year we started in Argentina. So what's interesting to start with is while we say this is a 5-year program, this is kind of like a rolling 5-year program because each country is kind of starting off at a different phase in a different year. Each country begins their work with a rapid assessment of the mental health situation in their country, and we run multi-stakeholder design workshops and processes and consultations to establish for each country 5-year objectives. From these 5-year frameworks, we prepare annual work plans for activities. So that allows us an element of flexibility that we can have for changing contexts and country needs in that process. Progress in the countries is variable. Each kind of goes at their own pace, at a different pace. They take on different priorities and they attend to the work and the needs in a different kind of order. These next few slides are very busy, and I welcome you to read more about the Special Initiative in other resources, but it just gives you a sense of some, and I have to stress these are just some of the achievements that we've been seeing in some of our countries. So like I said, Argentina is our most recent country, still in design phase. They're very much looking at a long-term process of deinstitutionalisation so that they can actually increase access to community and primary-based care. Bangladesh has made some exciting progress following some really dedicated government advocacy, and this is also the same with Paraguay, which is on the next slide. Both countries have actually succeeded to establish a dedicated directorate for mental health within their ministries of health. Now, this is exciting because it means going forward and in the long term, there will be a greater emphasis on meeting needs for mental health, and it means that they will, for the first time, get a dedicated mental health budget. So this is truly exciting achievements for these countries. Different inroads for mental health exist in different countries because there's different strengths and existing health services. So Ghana has been building on a lot of the quality rights work that they've been doing over the last sort of 3 or 4 years, and they're beginning to focus a lot more on the integration of mental health for people with other health conditions. So tuberculosis and HIV are going to be big priority conditions where we look at comorbidities with mental health in Ghana. For Jordan, they have a really active Jordanian Nursing Council, and that has offered us a means to actually strengthen the quality of services that are being provided in the general hospitals, and at the same time enabling us to work with primary care to help feed referrals where it's needed. You'll hear more about Nepal from my colleague in a little while or after the break. But Nepal is also really seeking to prioritise availability of mental health care in primary healthcare settings. As was described by Lisa earlier, many of the facilities are in central urban areas of Nepal, and we really need to try and get a much more geographically dispersed access to mental health services in a country like Nepal. So you're probably starting to see a bit of a pattern now where there's the special initiative is this blend of advocacy and policy work and a really strong focus on primary health care work, including the implementation of tools like MHGAP. But another pattern that's also emerging from our special initiative countries is what's actually being done before, during, and after emergencies. So in Paraguay, in response to the COVID-19 pandemic, the government was able to work to create virtual consultations for people with mental health conditions, and that resulted in a 500% increase in just 2 years. Because of the work that we're going on with the government in Paraguay and through the new national mental health law there, we're able to actually sustain those virtual consultations. So these virtual consultations from COVID will now start to become the norm in Paraguay. The Philippines has also used their significant work in trying to expand access to medications, which includes psychotropic medications, and their work in primary healthcare facilities in line with their disaster preparedness planning efforts, so that mental health and psychosocial support services are using the primary level services available in the regions without having to do too much additional implementation and more focus on referral when emergencies actually happened. And this was starting to prove as effective in the Philippines during their typhoon responses last year. Zimbabwe is another one that's also starting to use some of their COVID-19 responses to support some of their work going forward, particularly around the provision of community-based psychosocial support through religious leaders and traditional healers. Now, one of the most interesting ones is actually Ukraine, and I suspect that Ukraine's going to be quite a focus today. So what I want to actually say is that the special initiative started in Ukraine in January 2020. So we had 2 full years of work in Ukraine before the escalation of hostilities in February 2022. So key engagements and agreements with the Ministry of Health and the National Health Service of Ukraine before the current crisis has actually helped pave the way for a much stronger and robust MHPSS emergency response. I'm not going to pretend that it's perfect. It's always going to be a bit messy. But it was before the emergency that the government knew what they wanted to do. So the government knew that they wanted to implement MHGAP in primary health care. They wanted to use approaches like community mental health teams to support people with severe mental disorders. And they had already determined that they wanted to roll out some self-help stress management approaches to the general population. And it's interesting, you know, if you look at the original 5-year plan that we did in 2020 with Ukraine and what was last year released as the roadmap for the MHPSS emergency response and recovery, they're actually about 80% the same. So it was interesting that we already had something from which to build. And this means that the influx of partners, the influx of funding, and the influx of resources that's going into Ukraine now for the mental health and psychosocial responses are now also actually helping to build up the health system in Ukraine. And that's because the framework and the determination was there to actually expand the health system before the crisis became much bigger. So things are a bit different in the sense now that they are working at a much faster pace with much more resources, with a lot more partners than ever before. But it is ensuring that most areas of mental health are getting covered. So you can see that WHO's special initiative for mental health is not just about one or two interventions. It's not just about one or two mental health conditions. It's trying to look at a whole of systems approach, which is essentially those 6 key building blocks of mental health systems strengthening. And these approaches are providing a bit of a platform for the full integration of development, humanitarian, recovery, and other nexus opportunities as contexts in countries shift and change. Last year, we put out a request for proposals for a group to do some midterm learnings on our special initiative, and that was awarded to Queen Margaret University. The full midterm learning report is available on our website, but I just wanted to go through 2 or 3 key things that we learned from these midterm learnings on our special initiative. The first is to say that there have been 4 main achievements to date. And the biggest achievement that most people are saying and reporting from the special initiative is that it has established a platform to actually address mental health in countries. And this has supported the development of key policies and governance around mental health and determination to look at transformation of mental health systems. Services have started to expand, though we expect that will probably be exponentially greater in the coming few years. And the other factor that was a big achievement for the special initiative was the real engagement of multiple stakeholders in countries in the design process and in setting the priorities. And this included working with persons with lived experiences of mental health and psychosocial support conditions, psychosocial conditions. So these were highlighted by people involved in the special initiative, including governments, as some of its key achievements. How these achievements came about is kind of interesting, and it's been due to the dedicated and continuous work with ministries of health and other senior level influencers. So getting that senior level buy-in to the initiative has actually been really, really key. For WHO, having dedicated people at country level, such as Kedar that you'll meet later on, this has also been key because this has meant that there is someone walking with the ministry to discuss and to push forward the mental health and system strengthening approaches. Having the 5-year process and planning process was also seen as important because it helped people take that big quagmire of mental health issues. And there's so many, there's so many disorders. It goes across the life course. There's medical approaches, biopsychosocial approaches, there's many theories, but actually having a 5-year plan and trying to actually target a few priorities over that time has also been a contributing factor. And of course, none of this would have been possible without the financial support of organisations such as NORAD. We've also had SDC and USAID on board. And it's because they've made not just investments in mental health, but meaningful investments in mental health. So they're not just funding 1 or 2 things. They're actually looking at supporting the system strengthening process and appreciating that it is sometimes quite slow and sometimes quite challenging work. So we're grateful to those investors in the Special Initiative for Mental Health because that's helping us do that 5-year commitment and that long-term work with ministries for the system strengthening. Now, this all sounds very lovely, but it hasn't all been smooth sailing, and some of us have been kept away many a night with challenges facing this program. For individual countries and across the 9 participating countries, there's some really difficult things that we're trying to grapple with. One of our issues
Can you hear us, Alison?
Do-
We lost you for a moment.
I think I'm back.
Yes, you're back. We're glad you're
Okay.
back.
Okay. Welcome to the world of online. So I'm actually not far finished, so I won't be a moment. The ambivalent commitment is that governments know they need to do something, but actually getting them over the line to make real and significant changes is actually more difficult. So I'd use the example of task shifting. People like the approach, they understand the theory, they understand how it meets the need, but actually getting governments to change their cadres or change the terms of references of the people that work with them, this is actually a lot harder to do. So when we say that ambivalent political commitment, it's not that they don't want to do stuff, it's just that some of the things that need to happen are really big decisions. We're starting, of course, now to also approach with ministries the need for them to invest financially in how we manage mental health finances. And, you know, ministries are competing with lots and lots of other priorities. The other consistent message is we need a really good workforce and human resources to be able to deliver on the need that's required. So I'll just go through this quickly to say that the recommendations from our midterm learnings, they strongly emphasise our need to focus on even more political buy-in and local level advocacy, and this needs to happen from all directions, including civil society and persons with lived experience. We need to perhaps emphasise a bit more on the service user experiences so that we're mapping how they access services, and then this feeds back into attracting more political commitment to demonstrating the need for local level services. And finally, we need to get our numbers in order to demonstrate the impact of our work. I'm going to be the first to admit that I very much underestimated the complexity of monitoring and evaluation for the special initiative, and we're trying to work towards resolving this. It's actually quite challenging because information in countries is not always available, it's inconsistent, and it's something that we need to demonstrate impact, but it's actually different in different countries. So let me conclude by saying that this has been a very small snapshot of our special initiative for mental health. You can read more about it at our website, but I just want to reiterate a few key points here. And that's to say, we can really make a difference to national level mental health services and increase availability and coverage if we take an overall system strengthening approach. Linked to this is the critical need to ensure that we're meeting people where they're at. And this is by ensuring that services are made available at the local, minimally at the primary healthcare levels. And to do this, we're going to also be setting up countries to be able to respond more robustly and rapidly in sustainable ways during crises. And this is whether that's a natural disaster, conflict, climate change, or health pandemics, whatever kind of crisis. They fundamentally need strong health systems to be able to respond properly in those crisis situations. And ultimately, stronger investment in mental health over time will also increase the investment that people and the availability of services when there's MHPSS in emergencies work to be done. And there's no reason that development and mental health and emergency mental health actually needs to be in competition. They very much need to work hand in hand. So let me leave it there. Welcome any questions. Thank you so much for listening.
Thank you very much, Ali, for leading us through this big initiative, the special initiative. And I'm glad you didn't foresee all the challenges, because then you probably wouldn't have taken it on, and then we wouldn't have had all these achievements. So sometimes that is a blessing in disguise. I think we have time for one brief question now. Yes, please introduce yourself and ask your question.
Hi, I'm Uddhav, student at Oslo Med. My question is, thank you for your wonderful work and your presentation. My question is, you talked a lot about the initiative from the government sector or from the organizations. Can you also shed some light on this, on the people, like how important is it, the trust of people towards the health facilities or the practitioners or the policy to implement these services? And also, yeah, basically that.
Okay, so that was a little hard to hear. Was the question, how do we gain the trust of people to use the services?
Yes. How to build trust.
Yeah, okay. So I think one of the things that's unique in the special initiative is, well, it's not unique. It's been done many times before, but possibly not to this level or this scale. But we're engaging in every country as much as we can, service user associations. So they do exist. You know, people with lived experiences exist in every country, and many of them, most of them, also have some kind of associations or organisations with whom they associate, and they can do a lot of civil society advocacy and a lot of local level education. And for us, building up those service providers, service users and organisations is one way and one element of building trust to use services. I have to say also, I think this is something that takes a lot of time. So a lot of people may not trust services because they've not often been available, or what types of services have been available have potentially been violating people's rights. So, you know, if you come to someone and say that you are seeing delusions, they may be fearful that they're going to put you in a long-stay institution and you may never see the light of day again. So one of the education areas that we need to really emphasise is that help is available, and it's changing, you know, and that help is, many mental health conditions can be very well managed and some treated. So I think it's also a matter of time to be able to get people used to the idea that mental health services are not what they used to be, and that they can actually be something that's useful to them. I don't think there's an immediate answer. I mean, building trust is something that takes time. It takes many angles. And for us in Special Initiative, one of the key approaches to that is the integration with primary care and the integration and work with people with lived experiences.
Thank you. Thank you very much for the question and for the reflections and for emphasizing lived experience and also human rights in that. It was a great presentation, Ali. Really impressive to summarize all those challenges and achievements, and to emphasize. I really like that you emphasize the platform that it's given, so that it's not a competition between anxiety and schizophrenia or cognitive behavioral therapy versus traditional practices. It's really a whole of a system approach, and no wonder that it's challenging. But thank you. There were a lot of terms there, like MH gap and task shifting, that are very familiar to some, but less to others. But luckily, we will pick up on these also a bit later, both from the Nepal perspective with the Kedar, and we have Noora Brote, who does her research on the MH gap. So you can hear more about it after the break. But we hopefully get back to you with more questions as well. Thank you very much. And thank you. Our final presenter is Michael Udedi. I hope you are traveling safely and not driving yourself, Michael. And I hope you have a good connection.
No, I'm not driving.
I'm glad. But we're glad that you could join. Michael is a senior in the leadership of the when it comes to mental health in the government of health, at the government of Malawi for the Ministry of Health. So we're very pleased that you're with us. You have a very impressive list of publications and engagement, and I've enjoyed reading some of those recently. And you're also an adjunct associate professor at North Carolina, and you have done tremendous work in integrating mental health into physical health approaches. We have invited you here today because you have been one of the masterminds behind the work for prevention of suicide in Malawi, and so we've asked you specifically to talk about that. But I'd also like to take the opportunity to say that our hearts go out to your country at the moment, because we've been following and seeing these horrendous pictures of the flood, of the cyclone in Blantyre and the areas around, and it's just horrendous. And really hope that all your family is safe. And thank you for joining. We hope that we can see your presentation and that you can see your picture now. Please join.
Thank you so much for those wonderful flattering words. Please give me access to share the presentation, if possible.
Super. Thank you.
All right. Thank you so much. So it will be controlled from your side, yeah? All right. Thank you. I would like to present on issues to do with suicide prevention in Malawi. We have what we call suicide prevention implementation framework, which we developed from last year, and we have just recently finalized this year. This is in line with the government policy in helping people to access mental health services, but also reduce the burden of mental health, including the mortality secondary to suicide. Next slide. So yeah, you can just go to the next slide. As Malawi, like another country, we've been facing a number of challenges, which include pandemics like COVID-19, floods secondary to cyclones, and other disasters. However, we've had challenges in terms of deaths by suicide. We had a step survey in 2017, whereby we had 7% of our respondents who had seriously considered suicide. And more of them were women who were considering suicide as an option. And it was also higher, or it affected more with lower income levels. And 3.8 respondents before this suicide. And we also noted that the history of attempts previously, and 5.4% of the respondents had a family member who had attempted suicide. And the respondents also, we had noted that 2.5% of the family members had one of their member who had died by suicide. And when we had looked at the police reports, in terms of suicide situation in Malawi, we had seen that there's an increase. As you can see, from January to August in 2019, we had 116. While in January to December in 2022, we had 382 deaths by suicide, showing an increase in terms of deaths by suicide. Those who complete suicide, or who actually have died by suicide, the figures show that more men are dying by suicide than women, although the women contemplate on dying by suicide. But also the other challenge which is there, I think previous speakers talked about, is a stigma around mental health conditions, which affect help-seeking behavior among people living with mental health problems or mental illness. But also in the penal code of the laws of Malawi, suicide attempt is a criminal offense. So this criminalization of suicide attempt has brought in challenges, because people don't have, if you attempt and you survive, people do not want to seek help. In that case, they are bound to repeat the suicide attempt again. And also there's an easy access to means of suicide, like having easy access to pesticides and also other lethal means of suicide, which makes these issues to be complicated. But also another issue which is challenging currently is the issue of social media. There is irresponsible social media reporting in the country, or sensational reporting, whereby even graphics of suicide, people who have died by suicide, or any other issues surrounding the suicide are being reported in the social media. And last but not, I wouldn't say it's the last one, but it's one of those challenges which are there. It includes the socioeconomic challenges which has affected most of the individuals in the country, and this has also probably contributed to suicide because of poverty, unemployment, issues to do with GBV, individual or societal conflicts. These have got an impact in terms of suicide. So what have been the what has been a government response to address the challenges in relation to mental health as well as suicide? As a country, we developed the National Mental Health Policy in order to increase access to mental health care. This policy was done in the year 2020. But also we've been engaging the media houses in the country in order to for them to be reporting responsibly when it comes to mental health as well as suicide. But also we've been trying to build capacity of stakeholders, that's those who are providing mental health care. We've been training other non-mental health professionals or other non-healthcare workers in psychological first aid, narrative exposure therapy, as well as interpersonal group therapy. This reached a peak in 2020 when we had COVID-19. We had trained a lot of volunteers as well as non-healthcare workers in psychological first aid so that they will be able to provide psychological first aid. And this has got an impact as well in terms of supporting people who are probably having suicidal ideas. But also we've been promoting mental health awareness in the general population as well as in the print and electronic media so that people are aware on issues of mental health, but also where they can access help if they have any mental health problems. We had also produced a public service announcement on suicide prevention on where they can access services and also warning signs of suicide. But also we established a sectoral mental health and psychosocial support task team, which tries to coordinate all the stakeholders in relation to psychosocial support. But also we had established a task team prevention. And we've been conducting roundtable discussions on suicide prevention to make sure that we bring everybody on board so that they're able to provide necessary solutions into suicide prevention. Apart from that, we had started developing the suicide prevention implementation framework. This is the one this is the one which I would like to share with you just now. So the aim of this suicide, or the goal of this suicide prevention implementation framework, is to reduce suicidal behaviors among the population. This is in line with Sustainable Development Goals target 3.4, whereby by 2030 we want to about this.
You're breaking up a little bit. Can you hear me, Michael?
Yeah.
Can you hear us? Michael, can you hear me? Right. Yeah. Let's see. Yeah. Maybe go to the to Teams just to see if we can see. Se om det går se han på. Well, I'm quite pleased we've had as good a good connection as we have up till now. So I'm glad. Oh, excellent. Welcome back.
Hello? Can you hear me?
Now we can hear you. Yes, please continue.
All right. So I was saying that we have the core values and principles for the implementation framework, and these and principles are meant to provide a holistic care to those people who have survived from suicide attempt, but also in terms of prevention from preventing people from dying by suicide. So there are several. We have coordinated multi-sector approach, and in this sense, we are talking about the multi-sector task force, but also the multi-sector task force on mental health and psychosocial support, but also multi-sector task force on suicide prevention. But also we are looking at primary healthcare approaches where our interventions will go all the way up to primary healthcare level. But also we consider using evidence in but also human rights approach is part of this framework, whereby the issues, as I had indicated earlier on, that suicide attempt is a criminal offense in the laws of Malawi. So one of the approach is to make sure that suicide attempt is being decriminalized in the penal code, so that it's not per se. But also equity is part of that. That we do not discriminate individuals based either on age or gender or religion or other issues. And but also we would like to make sure that individuals are empowered, and we include everyone in terms of the prevention aspect of suicide. So the aim of the suicide of this suicide prevention implementation framework is to reduce suicide behaviors by reducing the factors that increase suicide risk and increasing factors that promote resilience. As such, we are going to highlight integrative evidence-based approaches to help prevent suicide at individual, systems, and community levels. And we have a number of key objectives for this prevention framework. We have the first one is to establish and operationalize a suicide prevention program at the national and district level. We want to make sure that apart from providing operationalizing this prevention program at national level, also want to make sure that district level they have also at district level they also provide prevention programs. But also to strengthen supportive strategies, which include the legal framework, which we said that we need to make sure that our legal framework does not criminalize suicide, but also issues to do with financing environment, to make sure that we're able to prevent the intervention measures, so we have adequate finances. But also to improve access to comprehensive, integrated and quality services for suicide interventions at all levels of care, and to increase awareness on suicide prevention, and reduce stigma and discrimination so that people are able to access services, but also to strengthen systems for surveillance and research on suicide. And we have strategic interventions related to each of the key objectives. For instance, when we say we want to establish and operationalize the suicide prevention program at national, district, and community level, we want to make sure that we have a coordinating point of suicide prevention, and we have to make sure that we have designated focal persons in ministries, departments, and agencies who will be able to coordinate suicide prevention at all levels, but also to make sure that there is an intersectoral committee on suicide prevention at district and community level, whereby different stakeholders participate in suicide prevention activities. When we talk about strengthening supportive strategies platform, we want to make sure that we collaborate with relevant stakeholders towards regulation of lethal means used in suicide incidences. For instance, people use pesticide. We want to make sure that we work with pest control board. We want to make sure that lawmakers are involved so that they're able to pass laws which can prohibit easy access to lethal means. But also issues to do with mobilizing resources, having key players like members of parliament and others will be able to help us to have enough resources. But also, as we said, we want to improve access to comprehensive care. We want to increase capacity of mental health and psychosocial care providers by increasing their knowledge and skills in provision of services. And we would also want to integrate and operationalize National Suicide Implementation Framework into existing helplines. We have different helplines like emergency medical services. We have what we call Chipatara phone. In English, you say hospital by phone or health center by phone, whereby people can call and get healthcare messages, but also they can get advice, but also they can get telecounseling through that Chipatara phone of hospital by phone. But also want to provide clear pathways for referral services and post-discharge for those who had probably attempted suicide and they've been taken care of. We want to make sure that after discharge, we are able to follow them up. In terms of increasing awareness on suicide, we want to develop capacity building program on suicide prevention to address issues like gender-based violence, issues about accessing social support, but also working with different media houses, as well as police, teachers, the youth, to make sure that they have adequate information related to suicide prevention. And in terms of implementation arrangement, the government ministries, departments, and agencies, in collaboration with other stakeholders, will form what we call multinational stakeholder task force on prevention, on suicide prevention and management. And each stakeholder has got a clear role or responsibility when it comes to suicide prevention. All this to make sure that there is a multi-sectoral approach, but also there's ownership, and that we are able to prevent suicide together, because it's not only one stakeholder or one ministry which can be able to prevent suicide. As I've already said, probably pesticides are under pest control board or agriculture sector. Issues to do with other means and other causal factors fall under other ministries, which is not necessarily under the Ministry of Health. So, as a team or as we work together, this will help us to have a good approach in terms of preventing suicide. Thank you so much for listening. Zikomo kwambiri.
Thank you very much, Michael. Thank you for sharing. And I think none of us had actually seen the documents before, and now we have a good overview of your strategic plans, and also of the amazing challenges ahead of you in implementing these. But I'm very impressed and very pleased that we got to see how you've been working, and also glad that the connection held up as well as it did while you're traveling. Thank you very much. Two things that I noticed: the human rights and legal aspect that Malawi is one of the 20 countries in the world with suicide attempt is illegal, so, and I'm glad you addressed that. And also the multi-sectoral aspects here, including pesticides, as you mentioned, that regulating pesticides can be as important as providing therapy, and that means that it is not in the health sector only that the prevention and treatment take place. We are a little over time, but see if there is one question either for Michael or for any of the other speakers. And we have two people who have signed up. Please introduce yourself, Tuva, and then ask your question.
Yes, my name is Tuva Rosvold. I work for Youth Mental Health Norway. As you gave your presentation, there was one question in particular that sort of popped in my mind. As far as I know, in Malawi, being gay is illegal. And so I was wondering how you work with the LGBT community to provide care for them. Or if you do, because we know they also have higher risk of having mental health conditions and doing suicide attempts and also suicide. We know that that group is very exposed.
Thank you very much for raising that question on LGBT rights. I think we take the other question at the same time, and then you'll have to answer both afterwards, Michael. Please introduce yourself.
All right, thanks, Michael. That was a very beautiful presentation. My question is a little bit.
Sorry, what's your name, please?
My name is Martin Otieno. I'm from Kenya, and my question is going to be a little bit difficult. I understand you did mention resiliency or building resiliency in the individuals that have tried to commit suicide. Just how much of that can be built in relation to the social, psychological determinants of health, remaining the same, despite people being resilient. How has Malawi, or how do you guys address the difficult aspects of external factors that promote some of these thoughts that come into the people that you see?
Thank you very much. Did you hear the questions, Michael?
Yes, I did. Thank you.
Please.
Thank you so much for those two questions. The first one, I think, is talking about LGBTQI community. So as a country, there was a moratorium regarding the LGBTQI. I know it's a challenge currently. The law is still there, but as you've seen, the framework has got guiding principles, and we are considering public health approach, human rights approach, as well as equity. So these are the guiding values and principles. So as we are providing services from the public health approach or human rights approach, we say we will not discriminate any individual based on whether it's about gender, sex, religion, or other issues. So that wouldn't be a problem, because we've even before even this framework, people have been supported. Probably gay people and others have been supported, not even considering their orientation or their religion or other things. With regards to the issue of resilience, yes, there are a lot of challenges. As of now, we are facing the issue of the cyclone, and we've seen a lot of people having problems with their houses being destroyed, losing a lot of people dying through the because of the floods in relation to the cyclone and other things. But also there are issues to do with socioeconomic factors. Yes, those are a lot of challenges which have contributed to an increase in terms of mental health problems, but also increase in deaths by suicide. However, as I was presenting the framework, I talked about multi-sectoral approach, and probably I didn't give the comprehensive aspect. It goes up to community level, at the village level, as well as the district level, whereby we have got communities as part of, whereby we have stakeholders who are part of the like multi-sectoral teams responsible for prevention. We've made sure that who are responsible for issues to do with support.
You're breaking up a little bit there, but Michael, can you hear us? We've lost your sound, but we had good responses to both these challenging questions. Can you hear us? Can you hear me?
Yes, I can hear you.
Okay, good. Yes, yeah, we heard most of your response, but then we lost you at the end.
Yeah, so I was saying we have programs which include farm subsidy input, where by the poorest are given farm inputs, others are given the social cash transfer, they're given cash to support them. But also, as I had said, that we would make sure that a lot of volunteers are trained in psychological first aid. And one of the programs in psychological first aid and mental health and psychosocial support is problem-solving therapies, where they would be able to help individuals to solve problems as part of helping themselves. But also, in terms of access to other support, is one of those pillars which we've included in this framework, so that we'll be able to link people to where they can get support as part of building the resilience. Thank you.
Thank you very much, Michael, for responding to those questions. And we will soon have a break. We have food, we have drinks, we have good people to talk to. Unfortunately, we can't offer food to our guests online, but I hope you also will have a break. I know that Harald will leave us during the break, so if there is a question or a comment for him, or also for Alison, we could have one brief question before there is food. No, I shouldn't have said food, should I? Oh, please introduce yourself and Henriette. That's okay.
Hi, my name is Henriette Risvoll. I'm a psychologist and PhD candidate in psychology, working in Malawi. So, Michael, thank you so much for your presentation, and I really want to commend the work that you're doing. I was just wondering if you could say something about how you will see the work on suicide prevention related to children and adolescents. Specifically, is there anything, will you do sort of try to integrate it into schools or even for younger children? I was just wondering if you have any points on that. Thank you.
Thank you for pointing to children. Since I mentioned food, please respond briefly to the question, Michael.
Thank you so much. Yes, we have an intervention focusing on children and youth. Because what we've noted in the reports, we've seen that children as young as 9 have also died by suicide. So there are some interventions which are targeting the children and the youth, especially targeting the students as well as the school-going children and the teachers on how to support learners in relation to suicide prevention.
Thank you. Thank you very much. thank you all the presenters for sharing with us. Alison and Michael will be available also for the next session. Thank you all. Thank you, Harald, and safe journey traveling towards Blantyre while we have the break, Michael. We'll see you again in about 20 minutes, or we'll meet again at 10:45 our time. Thank you. So. Vær så god, forsyn dere. Please, and let's benefit from each other's company. It's not very often And we will have Paul FIFA, here he is. Nora Brotte, you have arrived. Great, thank you. Please, here. So we have slightly unconventional seating arrangement. And it's not because I dream of being tall and looking down. No. It's because we're trying to make sure that we have a panel with where the panelists can see each other, and at the same time we can see the camera and the audience. We tried back and forth a little bit and decided this was the compromise that would meet most of the criteria. So please, yes. Well, thank you for not giving up and for being here. Thank you very much to the panel for joining. I'd like to welcome all of you. We have a fabulous group of panelists, and whether it will be a debate and discussion or just a friendly dialogue, we shall see. We have here we have Kedar Marahata, who represents the WHO in Nepal. Namaste, welcome. We have Frode Forland, who joins us from Addis Ababa. Frode is from the Norwegian Institute of Public Health. For Norwegians, he's familiar to most because he was one of the lead persons in dealing with the COVID situation in Norway. So we saw him on TV all the time. But now he is seconded to Africa CDC in Addis Ababa. And we're very pleased that he is also joining. And we have Ksenia Semenyak from SOS Children's Villages in Ukraine. Ksenia, you're in Kiev, I believe. And thank you for taking time out. We know that you have also very, very busy days and nights, and you're working very hard coordinating all the mental health and psychosocial efforts of SOS Children Villages in Ukraine, and under very challenging circumstances. And of course, we all follow the news, and hearts go out to your country and the situation. In the room, we have Paul Fife, who is the leader of health in NORAD. Your titles change often, but I see that you're still the same. So we are very pleased that you joined. And we have Nora Brotte, who's a PhD candidate at the Norwegian Center for Traumatic Stress and Violence, or against on traumatic stress and violence. A PhD candidate working on MH gap that you heard about earlier, and we look forward to all of your perspectives. Again, the bios of the panelists are also out on that, so you can read and be impressed like I've been. I have asked the panelists to prepare a very brief introduction, a 3-minute introduction or so, each about their perspective on the issue of today. Like the issue of today is, what should we do? What needs changing? From my perspective, what can be done? What are the main challenges, or how can this be dealt with? Because we have representatives from different organizations and perspectives, the interpretation of the question is also likely to be slightly different. I'd like to ask you, Paul, to go first. You are the Norwegian government today.
Thanks for the introduction, Ragnhild. It's great working with a Norwegian network on mental health and psychosocial support. I just want to say, Ksenia, pleasure to meet with you, and I'm sure I speak on behalf of everyone in terms of hearts and support going your way very clearly. But thank you for making the time to meet with us. And obviously, Kedar, we have not met before, but in some ways I feel we've met. Long-standing work with the WHO and multilaterals. And as Lisa said, my director, she was last week in Nepal, and I know that you met. And Frode, we know each other from a long time. Noor, a bit new acquaintance, but it's great seeing you. So I mean, these are the distinguished guests, and so on. Welcome. So why this meeting now, first of all? And I think the presenters have put quite well forward why this meeting now. I just wanted to add it from NORAD viewpoint, that we are both kind of looking at the progress in terms of the past few years, in terms of which partners we work with in civil society, with multilaterals. But we also are reorienting, shall we say, ourselves in line with both what we see is extremely important in global health and development, but also what are the priorities of the government. And I mean, personally, I'm very happy. I mean, been working in health for many years, but we see that the efforts in global health have really led to great progress in maternal child health. It's clear that HIV and AIDS, TB, malaria, the work is absolutely not done. But where would we have been now unless there had been 20 years ago a really push politically, but also communities and financially from various donors and governments to really address issues. And then there are so many crises. I think it's due to really to have the mental health and social situation of people-centered thinking, to really be able to say this is happening, shall we say, because of or alongside, it is about the people. And we've heard, shall we say, that the situation has increased in awareness at political level. But we see that it's great, I mean, having so many here, but the action is not in NORAD, we think. I'll say a bit about what we think our added value is. But what we see in general in health and development is that despite the progress, we need to shift the power to change the conversation and having really, shall we say, countries leading. And by countries, we put a special emphasis on the responsibility of national governments, but also local governments. But it's clear in many walks of life, civil society partners when are really important. And we see this also, and that's been the same case in this country, in Norway, that where the government is not able to or not willing to, shall we say, to step in, the role of civil society in terms of holding governments accountable, providing services, and so on is key. I'll come back to this because I do think the country ownership and the capacity of partner countries to basically prioritize, to plan, and to implement in an effective and inclusive way is where we need to go as we move forward. I really love the presentation from Michael from Malawi. I'll go a bit deeper into the next question in terms of some of the things he said, which resonate a lot in terms of that was basically government ownership and stewardship in action we saw there. Very clearly, PHC came up as part of universal health coverage. We see the need for integrating services in the health sector, PHC, primary healthcare, frontline, but also not forgetting community systems. And then very clearly, multisectorally, we see some areas where possibly it's possible to do more. We see very clearly, I'm very happy to hear the question around children and young people, but schools and also young people are shall we say, in a quite vulnerable situation in most countries. And we haven't talked that much about it, but substance use conditions goes hand in hand with some of the issues. So we need to be thinking about working across, shall we say, sectors, government, private sector, civil society, and so on, but also across sectors when it comes to how governments or how we work and think very often in silos. Be happy to come back to that.
Thank you very much, Paul. Not working?
Yeah.
Oh, okay, sorry. I keep going back and forth here. Sorry about that. So thank you, Paul, and welcome, Ksenia. We have invited you because you play such an important role and you are a voice from Ukraine today. And also you represent civil society. SOS Children's Villages do a lot of important work in many countries, but today we're asked not to represent SOS Children's Villages only, but actually civil society, because there are many organizations, Norwegian organization and other organizations that do a lot of work, as Paul also mentioned, on mental health and psychosocial support, and many of them are represented here, and all could have been on the panel. So, Ksenia, please, we look forward to hearing from you.
Yeah, hello. Let me start from the thank you to be the possibility of this meeting, of this great event. And I will be grateful to share a few theses to point it out, a few theses from the part of the civil society. So I would like to point out that interest in mental health in Ukraine increased in 2014, in 2015, when we have the armed conflict in eastern part of Ukraine. And while this context appeared, it was more humanitarian context. But then we slowly moved to the development one in 2018, 22, and then after the full-scale invasion in Ukraine, it's again back to humanitarian one. But I would like to point out that we're already working on the development part, despite that the emergency situation is ongoing. And here I'm totally agree with Alison that she mentioned during her presentation speech that there were many steps before the emergency, steps on preparation, which were done by civil society, which were done by state partners, institutions, affairs, and only the synergy of all stakeholders give us the possibility to be prepared. Despite that, all of us, we couldn't imagine the size of the emergency, the consequences. But anyway, this preparedness give us the possibility to move from already humanitarian context to development one. People in Ukraine, the same as Ukrainians abroad, refugees, they experience a range of extreme stressors, everyday changes of plans, relocation, loss of homes, physical injuries, and one of the main challenges that we see in civil society is how to reach all those who need the support, how to reach people in remote areas, how to provide necessary help for them. Let me point out that children without parental care, they're one of the most vulnerable categories in all others in emergency, and the need of psychosocial support for children is quite huge. This is something that we do we in SOS Children's Villages Ukraine and together with other partners trying to reach also children without parental care. All efforts of civil society from the beginning of full-scale invasion and before, they are aimed at promotion and advocacy of mental health and psychosocial support. I could say that civil society put a lot of effort in order to change paradigm in society regarding what should be done in order to keep your mental health, how to help in emergency, how to prevent burning out. Promotion of mental health and psychosocial support interventions that could be done not only by psychosocial specialists but non-psychosocial specialists who are working with children, families, who are working with vulnerable categories, and they could provide basic necessary support and redirect to the specialized services. This is something that we trying to build up in Ukraine during many of roundtables, many participating in various working groups, trying to create the system of redirection between all stakeholders. And the last thing that I would like to point out that all stakeholders in Ukraine clearly understand that mental health and well-being, this is one of the crucial key for the future recovery and long-term development and social cohesion. This is something that we, all representatives of civil society, trying to build in Ukraine.
Thank you very much, Ksenia, for that perspective and for linking humanitarian and development perspectives, and for pointing to the cooperation between different partners and stakeholders in that situation. We'll come back to you and look forward to hearing more. Then I'd like to invite Kedar to say a few words from your perspective. I know you could pick up on many of the issues given your present work and your background, so very excited to hear what you have decided to focus on.
Thank you. Thank you for having me. And I see a lot of my friends and colleagues there who is very, very well informed about mental health condition in Nepal. I see Heidi, Risa, Stola, Yurangnel. So yeah, so you can also have an informed discussion around that there. But it's very interesting, Ragnhild, how this workshop is building up here, focusing on emergencies, focusing on suicides, and then on civil society. Indeed, these three areas, working together with civil society, emergencies providing opportunities, and suicides giving kind of an impactful message to get some traction of policymakers on mental health, has been very similar experience in Nepal too. Especially WHO Nepal's work on mental health started very similar to our colleague from Ukraine was talking about 2014 armed conflict here, the earthquake 2015 earthquake response. So emergencies kind of provide some increased attention, both to the stress, both from the policy level, but also provides opportunity of some grants and some funds for civil society and UN agencies, where then if we could take this opportunity to work together and present a common voice for better advocacy, at least in Nepal's case, we could build some momentum around that. So while that was happening, and the government then developed a national mental health strategy and action plan in 2020 December, and then we Nepal got enrolled into special initiative, which came as a very useful time to kind of kickstart implementation, support the government to start implementation of their national mental health strategy with support from special initiative. But we share very similar experiences for mental health, as like previous speakers were speaking. We have very low supply, so there are a lot of supply related issues for services. Service availability, integration, human resources, psychosocial care, etc. But at the same time, there is not much demand from the communities. So there is less demand, people are not asking for care, but at the same time, there is no supply. So it's kind of when there is no supply, but then people are asking for better care, that would have generated a different kind of a political discussions. When there is no supply, but also low demand for services for a lot of reasons, stigma, lack of awareness, kind of mental health, poor mental health literacy in the population, etc., has also resulted in a lot of barrier to demand care. So then for the authorities and the governments, it's like, okay, there is not much demand, so probably we don't need as much kind of a situation. So this is very this is similar in different settings. And lately, when there is some demand growing, but then it is for very visibly distressed situation, severe conditions. So then informed by that, the service development is also more focusing to medical care to severely distressed or those with having a moderate to severe kind of a problem. So this is the situation that we are at, and we are trying to attempt it as integrated into health systems, and then strengthening health systems or preparing health systems to better provide mental health care, starting from primary care, or rather with a special focus on primary care with a special initiative in the country, which I probably will speak later when prompted in the question. So I'll stop here. Thank you, and over to you.
Thanks, Kedar, and thanks also for raising the issue that when there is no demand, nobody asks for it. Why should we provide it, or should anyone? And we look forward to hearing more about the role of primary health services and the community-based services there. Then it's my pleasure to ask Frode Forland to say a few words from your perspective.
Yeah, thank you all, and good afternoon from Addis. I think to me the most important thing now is that we are not trying to establish new vertical systems for surveillance or interventions regarding mental health. We've had these big vertical programs, for AIDS, for TB, for malaria, which have been useful. But I think now there is an understanding that also those systems really needs to be integrated in the whole health system, and the same with vaccinations. We need systems that can handle and cope with all diseases at all levels, as far as I see it. And I think is building upon what also Paul Fife was saying, even though it was a bit difficult to hear you, Paul. We have units, of course, at the Norwegian Institute of Public Health and also at Africa CDC, at WHO, which are focusing on different topics, which is probably needed. But at local level, we really need personnel skilled to be first-line responders, carers, diagnostics for all kinds of diseases, on NCDs, mental health, and also on communicable diseases. We need community health workers who can be the first-line responders, community health nurses, and community health doctors. And my background, my professional background is as a community doctor in Norway and in Zimbabwe. And I think there is also then a need for a kind of referral system for difficult cases that can be lifted to another level. And I just read a review we've done from Africa CDC, like in Liberia with 5 million people, there is one referral hospital for mental health. And the same applies to Sierra Leone with 8 million people. So I was working as a district medical officer in Zimbabwe, and the psychiatric or mental health cases I saw was about epilepsy. People didn't get their proper treatments and they got brain damaged. It was about suicide. It was the use of pesticide, Rogor, and a lot of also physical attention to those at the local hospital. It was full-blown hysteria attacks. It was about domestic violence, about psychosis and delirium, and also people moving around with strange behaviors and not having access to care. And the director here of the unit for non-communicable diseases was saying the colonists, they taught us how to call them lunatics and idiots. But we have come much further now. And there is, for the time being, I would say, a strong focus on this in Africa CDC, even though this organization has been built up to care for outbreaks, which have shown to be useful when it comes to the Ebola outbreak just in Uganda, about the COVID outbreak that we've just are partly still in. And I'm sorry to say, yesterday it was also confirmed there is a new outbreak of Marburg virus in Tanzania, which is another hemorrhagic fever virus on the same severity as Ebola. So short about the focus areas of Africa CDC, we are mostly speaking about our strategies through what we call the new public health order, which is building strong institutions, securing local production of medicine and vaccines. It's about workforce development and respectful, action-oriented, long-term partnerships with partners. And finally, also to increase investments in health in African countries. And there is a specific now NCD and mental health injuries plan that is in its implementation phase, where number one is a priority on mental health in all national plans for the countries of Africa. It's about advocacy or political commitment to end stigma and to avoid exclusion of mental health in countries. And it's about multi-sectoral actions, about workforce strengthening, funding, and also to develop technologies that can be helpful for mental health. And one of the things they've started on is actually also to try and really build in mental health and psychosocial support in health emergency response, which has been a kind of natural starting point for an organization focusing on emergency response. And I was in a workshop in November in East Africa with the East African countries, 14 of them, with one kind of a key person from mental health and one from emergency response in each of these 14 countries. But the funny thing that I realized was that this was like very much a one-way workshop. It was a lot of experts coming from mental health and psychosocial support to tell the people in emergency response how to work. And there was really no other way information. And I think it's a need for both sides to understand how it is to work in a crisis situation, also to save lives when there is an ongoing outbreak of Ebola, like it was the case now in Uganda. So I think here we need also to have a two-way communication to be able to better integrate those services in preparedness response. And I think COVID has been an eye-opener for many of us to see how these things are extremely interlinked, the mental health side and also the somatic health or the infectious diseases for that sake. So I think that's a kind of reminder for how we can work also in integrated systems and then starting on the lowest level. And you were asking about barriers. Maybe I can come back to that later, Ragnhild. But just to remind us all about the situation that we are in. Many of us here from the north, from the global north, as we say. And there is a book to be launched at Makerere University in 3 days, which is called White Saviorism in International Development, Theory, Practice and Experience, where they stress what is needed now to get from poverty to power is to listen long enough to the voices of those who you claim to work with. It's to listen to how they perceive their own development and don't impose your own ways on them. So I think there is something here also when it comes to how we should build up a stronger mental health approach or ways of supporting and working as partners. We need to listen long enough. Thank you.
Thanks very much, Frode. So much I would like to pick up on immediately, but we'll come back to you. And thanks also for bridging the introduction to the final panelist by emphasizing frontline responders and community health workers, because even though I sit here in a strange position just behind you, feel a bit psychoanalytic about it here. But I think you need to be there to be seen. I am very glad that we have you here with us. And please, what would you like to share?
Yes, thank you. Can you hear me? Yeah. Like Ragnhild said earlier, my name is Nora Brotu, and I'm a PhD candidate working with implementing the MH-GAP, which is the Mental Health Gap Action Program in primary schools in Uganda. So first of all, I just want to explain for those who are not aware or familiar with the MH-GAP. It's an intervention aimed at increasing mental health literacy, so knowledge about mental health, and reducing mental health stigma, which are topics that have been brought up a lot today. And the framework is actually developed by the WHO, aimed at health sectors in low and middle income countries. We're adapting it to the school sector. So that is a very big project. And I think my main points today is that as mentioned, I think it is very important that we focus on context-specific interventions and methods, and that we cannot just create something that we have seen has worked, for example, in high-income countries or even in other low-income countries, previously, we need to consider the context that we're in. We need to really listen to stakeholders and to the community when we want to implement something or when we want to, for example, integrate mental health into the primary healthcare services. We need to take a step back and listen and really use the time and build trust and also increase literacy, increase knowledge, have information campaigns, awareness campaigns, and not rush everything, because not everything is, for us working with research, we often think that things are that we do not need to explain everything. Perhaps it's very obvious for us, but I think that just taking a step back and really listening to the ones who will actually work on delivering these methods day to day, and that they also have a sense of ownership of whatever they are changing or implementing. I think that is very important. And I'm gonna keep it pretty brief. I'm pretty fresh in the PhD field and in the global health field, but I also want to emphasize that by integrating mental health services into the lower levels of the healthcare systems and also schools especially, we're able to reach many more people, many more individuals who need help. And this is a very important aspect, and which is why we're choosing to work at schools, because most children in Uganda do attend school, and it's a good place to reach as many as possible. Another aim of the intervention is to more effectively identify and also support children in need, but also that we create systems for collaboration with the health centers and other sectors for better referral and better follow-up. Thank you.
Thank you, and thanks also for explaining MHGAP, the flagship from WHO. Please just give me a sign or raise your hand if you want to respond either to the presentations earlier or to each other. Otherwise, you know, I have about 200 questions prepared for you, and so does the audience. So do not worry. There will be questions coming, but often, but I'll try to keep my head going back and forth to see if you raise your hand on the screen as well. Ksenia, could I start with you and just ask you from your everyday life there, what do you think are the main barriers to actually providing mental health services and for prevention and promotion of mental health? If you were to pick out one or two main barriers, what would you focus on?
Yeah, this is really an actual question for Ukraine. One of the most challenging barriers, this is lack of awareness of mental health and psychosocial support. I mean, what actually I mean? When, for example, psychosocial specialists, they are coming to unoccupied territories, the occupied territories of Ukraine, and starting to provide help, mostly population, they do not recognize that they need help. They do not actually know what is it. And during the evaluation of the needs, evaluation of what kind of support should be provided to these communities, the specialists, they see that there is a demand, but people do not translate this demand. So this is something again, regarding advocacy, regarding promotion in society. And one of the barriers, this is cross-sectoral cooperation. This is something that is ongoing process. There are much effort put in it, but there is still not enough in order to build the resistance system, in order to build the system that could reach everybody who needs support.
Thank you. And you say the cross sectors, different sectors and different partners. Do we still compete? You know, is it still a competition between different actors and different institutions, or Is there coordination and collaboration? This is for anyone. Do you see that in...
From my point
yes.
of view, there is still competition, truly. I mean, even despite that, in our case, we are trying to build a roadmap. We are trying to involve all stakeholders, but still the competition takes place.
Thank you. You mentioned lack of demand, and so did Kedar. So it's interesting to see the similar experiences across different sectors. One issue that has come up is just, as you said, Frode, no more vertical initiatives, but whole systems. But how do we do this in practice? You mentioned the primary healthcare and communities. Well, all of you did, but you did, Kedar. How do you do that in Nepal?
Yeah, one of the approach that that we are taking, and I feel important even for to overcome a barrier and promote health seeking is making services available. So many times, if we interact with people who try to seek help for mental health care, are not responded well from health facility because of several stereotypes or lack of skill from a provider. So I think service being available at lowest level, who responds to the need, is very, very important to have positive experience of people who indeed sought help. This then will feed back to the community that similar situations, if we get help, you can get better, and then the services is available there. So this kind of a feedback and the interaction with health facility and community is, I think critical link here to promote health seeking in mental health care. So in this context, again, integration into primary health care has been a focus of special initiative in Nepal and even before that. Again, through, as our colleague kindly explained about MS gap style approach of integration. Even then, there are challenges to integrate mental health fully because the training, the MS gap itself is a very heavy and condensed package for primary care provider such as ours to be able to deliver. So there are challenges, but then this is the approach that we're doing step by step, and there has been some successes to our service availability.
Thanks, Kedar. Alison, would you like to comment on that?
Thank you. I just wanted to raise in a little bit on the stigma issue and just make a comment that last year the Lancet Commission issued a series of documents around evidence-based approaches to reducing stigma in mental health. And what we know is the most effective way of reducing stigma is to get people to actually engage with and have relationships with persons with lived experiences of mental illness. So one of the things that I just wanted to reiterate to Ksenia and Kedar and build a bit also on Frodo and Paul is to say the more we're engaging communities and listening to people with lived experiences, the more they're involved in policy development with government, the more that their voices are being heard, the more likely we are to build trusting relationships, the more likely we have opportunities of that meaningful listening that needs to take place, and the more chances we have of creating more demand and more help-seeking behaviour. So I do think stigma is a really important issue that needs to be addressed, but it's something that needs to be addressed in a very personable way. It's not something that we can do great big campaigns about. So we can do a big campaign to try and reduce stigma, but actually the most important way to reduce stigma is to have people living with mental health conditions speaking to policymakers, people living with mental health conditions supporting the training of primary healthcare professionals. So I just kind of want us to think a little bit around the role of persons with lived experience in that whole process. Thank you.
Thanks, Alison. And the role of people with lived experience in, as you say, policy making, in service delivery, in at all levels is really one of the main shifts over the last 10 years when it comes to global mental health, to see that this is not a luxury, it's not just a right, it's actually it's also necessary. It is a fundamental right, but it is also one of the few things that actually seem to work. And perhaps that I could pick up on what you said about person-centered, Paul, because is that part of what you meant by people-centered, or were you thinking of something else?
So the sound, is it better, Frode, now, or do I need to speak louder? It's fine? Great, perfect, thanks. People-centered, it's all about we have to address not diseases or conditions, but people. So I mean, it's a term that has come up also at WHO, but many places, which seeks to remind us that when we address the big crises or work, shall we say, in systems, let's have a focus on the people, persons, and really direct efforts, shall we say, to both involve, but also very much look at the implications of actions which are done. In particular now that on the Norwegian side, we will be moving towards a systems-oriented way of working in health. So that is why also we think this seminar is so interesting, because it's not only about talking about systems and institutions and so on. So it's really having the focus on people. But I want to go back to what Ksenia said around competition. If we manage, there will always be competition. I mean, we have interest groups. There are power games. It's about undue, shall we say, influence from certain private sector actors. So we have to turn this into a healthy process of priority setting, which basically both involves that the government, again, is responsible. And then perhaps if I have time, speak about emergencies. I'm very happy that the Ministry of Foreign Affairs is here, since the humanitarian section and what happens in emergencies is so important. So I mean, it's a great partnership going on. But it's about priority setting, which needs to be based on evidence. I think the work, we have this global evidence, which is very clear, 1 billion people and so on and so forth, disease burden. It needs to be local. It needs to be recognizable. It needs to be owned in country. So research evidence is very important with local actors. The second is that there needs to be an involvement from communities. We can learn a lot from, shall we say, other initiatives also in health, but the HIV/AIDS crisis would not have been solved without, shall we say, communities in the south, in the north, had been really pushing for political solutions. And this also addresses some of the stigma and discrimination issues, that it is really important to have the voice, to have them at the table, and as much as possible, I say as much as possible, as part of decision making. So that's the priority setting. So I mean, the fair financing thinking around having inclusion based on evidence, and then a rational, as much as possible, way of making priorities for policies, for financing. This is where mental health and psychosocial support systems needs to be placed. It needs to be mainstreamed into mainstream political, shall we say, discourses. Parliament's very important. So it requires awareness. And I really like the issue around the lack of demand or limited demand. It's about public awareness overall. And probably one is on the way, but more needs to be done, very clearly. And just what was mentioned around the global support to systems, like Frode mentioned too. I mean, I'm very happy to hear this discourse coming up. We hear it more and more from partner countries. Africa is one example. So shifting the power where decisions made. And we have seen great progress, as I said, but we need the global international support in terms of priority setting, in terms of finance, needs to be shifted in support of country priorities and plans and systems. So this is something we are engaging in. It doesn't mean that we pulling out from vaccines and different kind of very important, but it's the way, shall we say, the discourse is held with countries, and the way both technical support, but also not least financing is channeled, that needs to basically be changed. And it's a huge challenge for the next few years, because finances are not increasing.
No.
ODA is flattening, emergency support, of course, humanitarian is increasing. Unfortunately, to put it that way, fortunately and unfortunately, the climate crisis will also, shall we say, affect a lot what we are doing in this space. And unfortunately, at this time, the fiscal space of most developing countries is at best flattening, but it's going down. And we see also the trend we've seen in health. When more aid is coming in, less domestic resources go to the health sector. So, I mean, this is complex. We need to work on this together. And maybe one thing also to challenge us, and in terms of primary healthcare, we need to be serious on this, because we're quite good on interventions, single interventions. We're not very good at primary healthcare. We have the high-level meeting in September at the UN Assembly. Everyone is going to be for UHC and for PHC. We need to do it in practice. It's about human resources. A lot of the issues in healthcare is about the quality of healthcare. It's about really having skilled, but also open-minded and people-centered, shall we say, health staff of all categories. And again, stressing community systems. This we need basically to unpack. Are we talking about volunteers? Probably we are not talking about volunteers. This needs to be sustainable. It goes back to actually having a workforce, all types, that are able, shall we say, to handle issues that are usually hidden in families, in countries, in communities. And not to sound like a health sector, shall we say, centered person, this cuts across sectors. So I'm very happy to hear Nora talking about the health, the schools. We had a meeting with UNESCO last week. We're here on the occasion of a comprehensive sexuality education conference, which is also about stigma discrimination. It's not only about condoms, it's about values, it's about assertiveness, it's about setting boundaries. I'm very happy to see here that also UNESCO is increasing its work in bullying, in mental health and psychosocial support, because it occurs every day, everywhere. So one example of a sector and that is really important for children and young people. But for the teachers and, shall we say, the support system needs to have the skills and also having the assertiveness to go in and basically work on the prevention and promotion side.
Thank you. You raised so many issues there. I'd like to follow up on Frode. Your turn next.
Yeah, thank you. There was a lot of things to comment, but I'll try and be brief so other people could jump in. But I think, as Alison is saying, I think one day we are a helper. The next day we might be in need of help. And I think it's extremely important that we can talk about that. And that applies to almost all of us in different stages of life. And I think it was extremely valuable for the Norwegian mental health system when the Prime Minister went on sick leave due to depression. And I think we need some of these champions in all countries who can also raise the questions of mental health and be proud politicians and doing that. And related also to the legal frameworks, we talked quite a bit about decriminalizing suicide, but there is also a need for legal frameworks to assure mental health services in many countries. So it's also a way of working with the legal frameworks in a positive way. And I think when it comes to priority setting, Paul, it's about a power balance between the North and the South. And it's about the power balance within health sector. And primary health care and mental health care is on the lowest level in this status business. And I think the balance here, I should say, about between mental health versus physical health or somatic health is part of the problem here and the barriers, as well as the stigma issue that we have been touching upon. And of course, then also to be more practical on training of workforce and also capacity building for health systems related to mental health at all levels. At Africa CDC, there are 3 people now working on NCDs, including mental health. one person designed to work on mental health. It's a psychiatric nurse from Eswatini for 1.3 billion people of the continent. It shows how we also need really to strengthen these organizations that we can work with as equal long-term partners. Thank you.
Thanks, Frode. For many of these issues now, I'm thinking that you bring up integrating into community-based services, primary health services, physical health, the family doctor and the community nurse and the community health workers and also lay workers. They can, and we have shown, to play a very big role, and that was how MHGAP started, to try to make the primary health worker be able to also respond to, detect and respond to common and less common mental health problems. So the MHGAP, where does it stand now? Could you say something about that, Nora? Is it just one of many, and have we got lessons that we can use, or?
Yes, so we're currently organizing an MHGAP expert group, trying to collect experiences from people who have real experience implementing MHGAP in different settings. I know Kedar is one of the members, so thank you for that. For our project, which is what I know most about, right now we're adapting the framework to suit the school settings. We're having long meetings with people in Uganda, stakeholders, community members, and really trying to let them lead the process while we're just listening and taking in and maybe structuring a bit, but really it's their work, and we're really thankful for that. And the aim of all of these, and also of the expert group development, is that we can create something that can be used and can be scaled up initially in the rest of the country. We're focusing on one area, Mbale in Uganda. And so the goal is to create something that can be scaled up and used in other areas as well, and hopefully also other low and middle income countries wishing to create these interventions at schools. So that's where we stand at the moment. But also I would like to just emphasize that it is often context specific. So that is also something that we have to keep in mind. Did I answer your question?
Yes.
Okay.
Very good. Thank you very much. Thanks for that. We're coming towards the end. So if anyone has, prepared some really important messages that you want to share, this is the time. Nora has an important message she would like.
Yes, I just feel like it's important before closing off to mention that there has been a lot of people have implemented the MHGAP, and I know a lot of you are familiar with it, much more than me. But there is also it's also important to remember the research done on it, and there's not a lot of existing research available or done on it. And like you also mentioned, we're very good at single interventions. And I think that we have to, moving forward, focus on how the resources we put into these interventions can be sustained over time and how they can be integrated into the already existing systems. And that is basically implementation research. And I think that it's a very important focus to have moving forward whenever we want to see a change. Thank you.
Thank you very much. Is there a question from the audience? Oh, there are about 50 questions from the audience. Then I think we'll have to organize a new seminar very soon. And I think Monetta was the first one, and that will be the only one we've got time for right now. But I definitely think we should meet again next week to follow up.
Thank you. I'm Monette Indal from Adra, Norway. We do work in many countries, among them Ukraine. But I have a question, because we talk about, in the network, we are occupied about mental health being the amplifier of everything. So it's supposed to be multi-sectoral to manage, especially where human resources is crucial. Now, I wonder, because we are so much in health sector, and we, NORAD also is now organized after the SDGs. What is the strategy and what do you want to do to make sure that mental health becomes the focus on all the other departments as well? My organizations, for example, are under the education department, so we work in education and work with mental health in that. So what is the strategy to make sure that mental health becomes a part of that? And also the second is, we always talk about research. In mental health, there's a lot of lack of good quantitative research. So how do you sort of get that gap? You want to have the research behind what we do, but we also want to put multi-sectoral. Yeah, if you can.
Thank you very much, Moneta. Would anybody like to reflect on her question? One of her questions? Strategy for intersectoral work, for example? Paul? Kedar? Kedar first and then Paul.
Yeah, thank you. That's a big area to work on, and it's very difficult. And we often talk about collaboration and multi-sectoral, and in our small spaces, it boils down to an individual and their responsibility to deliver. So one probably area that works in fostering multi-sectoral, at least we've tried, is not asking them to do a health work, but then bringing in mental health to their interest. The colleague was sharing about education, so how mental health is beneficial rather to education. So it becomes then the education work, not a mental health work. So oftentimes we ask a lot, do this for health, but then forget what's their interest. So linking mental health to other sectors' interest would be, I think, important, and then it is seen as the education work or labor work than a health work. So that's one thing that we could do. And an interesting example of mental health featuring in development report earlier that we discussed is the one. So similarly in labor force, school, so in other areas we could build in mental health interest to the work stream and that they're doing, and then it may happen. So that's one practical thought I wanted to drop in.
Thanks for that. Since we are closing in a moment, then I'll just remind you, if you have a final word of reflection or something you want to share, please do. Paul, this will be your chance.
My chance, thanks. So first of all, I was thinking of just supporting what you said, Nora, in terms of operational research, implementation research. We think that's really important, including innovations and so on, but see how it works within different contexts. To the question directed to me or to NORAD, I mean, first of all, we are politically instructed, and there are so many crises. I'm not totally sure that, shall we say, in addition to awareness within the organization, which we are doing, I mean, this is one example, we do a lot, shall we say, of that kind of work, and it's clear we could talk about gender equality, human rights. I mean, it goes together. I'm not totally sure if it befalls us to have a special initiative across one institution on mental health. So it goes back to mainstreaming. And I'll be a bit proactive. I think it's more important what happens outside of a Norwegian institution such as NORAD than what happens inside. That being said, we do think we play an important role. I mean, we provide support with excellent partners, some on the screen and some in the room. But we really need to work together on how to implement. It's not about this is important, it's how are we going to implement it in what arenas? Policy, legislation, and not least what we talked today in terms of integrated approaches. I think that's perhaps my main message is not single interventions, integrated, and working with those partners that are best placed, whatever sector, to do so. Health is important, but it goes far beyond the health sector.
Thanks very much. Frode, please.
Just very short to say, maybe Africa is showing the way here. They've set up a multi-sectorial committee within the Africa Union to support mental health with 8 to 10 departments on board. I haven't heard about such a thing in Brussels so far. And then I would say, as a kind of closing note, listen to the voice of those you want to work with and normalize the mental health reactions and illnesses among all of us. Thanks.
Perfect. Thanks very much, Frode. Alison, please. Ali has frozen, even though she's in Nepal. Ksenia, would you like to have a final word, and then we'll have Alison. Oh, sorry. Yes, Ksenia, and then Alison afterwards. Yeah.
Yeah, I'm just totally agree with colleagues that it should be more sharing of good practices, what is working, and also popularization of cross-sectoral cooperation, like some good practices. It should be spread around other countries in order to receive a necessary result. Yeah.
Thanks very much. Alison, please.
Thank you. I suppose my last comment is really just a pitch. And the pitch is to say that if we focus on strengthening mental health care at the community and the primary healthcare levels and all of the aspects that go with that, you know, that's where you actually end up with some natural promotion and prevention work. You end up with identifying people. You end up supporting people in Ukraine, for example, who are on the move because they've still got access at local levels to services. You support people with substance use issues. You support people at risk of suicide, and you support the strengthening of emergency preparedness. So for me, that strengthening of the primary health system and their ability to integrate and work with mental health as part of that UHC construct is really critical. And I suppose my final pitch is to say that it is also something that takes time. It's not something that happens quickly, and it's not something that can happen from, you know, from one emergency or one intervention. It's something that is evolved over time. And I suppose that's just my final pitch, to go local.
Wonderful. Thank you very much. Thank you all very much. I am going to leave the final words of conclusion and summing up all of this to my good colleagues Heidi Vestborg-Stil and Ståle Stavrum. Heidi is from the International Child Development Programme, and Ståle is from FORUT, all part of the Norwegian network for global mental health work. Thank you, everybody. We've broached on so many topics on the different stakeholders and collaboration and coordination, on lived experience and ownership, on human rights, and on economic and social development. There's so many issues, and not least the link between humanitarian and development work, and how global mental health is truly global and concerns all on a personal level as well as on a national and international level. For me, thank you very much to the presenters. It was great to have representatives from UNDP and from Malawi and from WHO. Thank you, Alison, Harald, and Michael. Thank you to the panel. It was great to have you, and I really apologize that you were stuck with really good questions, but I hope we can meet again to continue the discussion. Please join the Norwegian Network for Global Mental Health. It's open for all with an interest in global mental health. And on that, thank you for me, and thank you again to the panel.
All right. Okay. First of all, so wonderful to sit here and listen, and thank you to Ragnhild for wonderful taking us through this day, and to all the panelists, and we'll come back to that. But I just want to start off by, is it not on? Is it on now? There we are. Thank you. Sorry. I started up saying thank you to everyone, and then was wonderful sitting here. I think we have kind of 2 points, and the one is that we want to kind of sum up, seen from the Norwegian Network on Global Mental Health, where Ståle is the leader of the network, and I think maybe it's fair to say I'm one of the initiators. I think one of the main issues from today is this learning together. Paul pitched that in a setting just recently. And I think we have heard that mental health is an area where capacity is on the rise. From several, we've heard that. And we've heard that it's a need, that the need is dawning upon us all, which is wonderful and so important. And there has been an slowly increase of this capacity during the last 20 years. It's slow, it's sure, but it is slow. However, there is a proverb, and it says it's an African proverb. I didn't double check all that. But if you want to go fast, go alone. If you want to go far, go together. And I think at some strange point, the fact that it's been slow has also meant that we've joined forces. Because you see that this WHO worked together a lot with experts on global level. Then you've had these national working groups with experts and researchers and practitioners, like in Nepal, other places. Also in Norway, where you have this network thinking. And I think that is where it's not, and it's a south-south as much as a north-south. And maybe that time, as Alison was talking about, is one of the key takeaways that it's important. However, we are actually out of time. Long time ago, we're out of time. So how on earth do we then continue this work going together? So therefore, the next steps, what would be the next steps? And I just want to keep on to that. We need arenas for discussions, not stopping with easy answers. Yes, vertical, it's so important, but we know that what happens with vertical issues is that mental health goes away. We forget about it. So not stopping with easy answers, but kind of continuing those talks. Therefore also kind of, because these are the areas, and I really like that, it's in arenas where you do these discussions that you get the accumulated knowledge. Because this is knowledge which is very low in a lot of countries. So by listening to each other and ensuring this cross-cultural, cross-disciplinary, multidisciplinary, cross-sectoral talks, then you can get much further. And I know that is one of the buyouts of Nepal. That's one of the buyouts of the Norwegian work on the global mental health. So yes, I just want to end with something which I usually don't talk a lot about, and not at least two positive terms, and that is, but we need milestones and indicators. Have you ever heard me say that? Because we can't just talk. There are crises, I agree with you, Paul, there are crises, that cuts all over. But there's no doubt that if we want to work with these crises today, we can't just continue as business as usual. We need to look differently, and this is an area where we need to look once again. So with those, and there, I think again with using the capacity that we have, we are here as a network. We are here to collaborate in different areas, maybe more multi-sectoral, more cross-sectoral. And we would be happy. We're a lot of both organizations, researchers, individuals who would be happy to be part of whatever needed here or there. So that was my...
Thank you. I would like to... I cannot sum up all of what has been discussed today, but I just want to put my finger on a couple of things. We are talking about systems strengthening, but it's not just ordinary system strengthening. It is a systems strengthening that has a wider perspective than just strengthening the health system as such. Because the fundamental idea that underpins the World Health Organization's approach is one which we support very, very much. In their special initiative on mental health, they actually have a very grand vision of engaging with a diverse and heterogeneous set of actors, many of whom are non-specialists. They are not mental health professionals, but you need to engage them. And it is a grand vision, but it's also the only realistic approach, because we are working in a world where mental health is not being addressed well enough just about anywhere. There is no good example that we have it down, that we have it sorted. We don't have it sorted. But we do understand that a whole of society approach requires the engagement of a lot of these different actors. And the two of us coming from the civil society side, we have our part to play there. Because what is this about? It's not only about treatment, which is the traditional mandate for health sector. Treatment, making people well again. It is also on prevention, it is on attitudes, it is on stigma, it is on things that can take place in interaction with people in communities. And that is where civil society organizations have a much better platform, much better capacity to actually do some good, even though we might not be experts in this. What we as civil society organizations do need is expertise, that there must be national level expertise in the countries so that we have somebody to turn to. We can do basic things at the community level while being non-experts, but there should be somebody to consult with and somebody to refer to. So mentioned several times have been referral mechanisms. And all of this is a perspective, an ecological perspective on systems actually. That you have different actors that can play different parts and playing to the different strengths. How to do this in a world as complex as ours? Well, it's first of all, we have to make sure that it is locally relevant. It is people-based, as has been pointed out here. And that means the engagement with people who have lived experience. It is with people who are the peers and the families of those who are suffering. That requires community work and a different set of skills than perhaps typically a typical Ministry of Health is focused on. So I want to point to a couple of things in this WHO research that Alison referred to on the key challenge of the special initiative. That was ambivalent political commitment. And the key achievement was senior country level buy-in. Both of these have in common that it means to address ministries of health and politicians in the country and to effect change. This is the biggest obstacle, this is the biggest achievement when it can be done. So again, it's that kind of, these achievements don't come about just like that. It may require quite a lot of awareness raising, political advocacy, where civil society organizations could join hands and play part of it. I think that is very necessary for it. I think our experience, having worked in Nepal with our part of strengthening the mental health system in my organization, we have experienced that once the central level, that is the Ministry of Health people, are adopting the agenda and setting priorities, that is the key to activating the other actors. So that making room for the rest of us to actually play this part in the grand vision that WHO has. Unlocking capacity, actually. So I think that the presentations here today also have shown that there are some very real challenges in this kind of systemic approach. They can be very basic and simple and cultural in the sense of the struggle between the somatic side and the mental health side. But it can also be between government institutions and civil society organizations. They may be pulling in different directions and have different cultures. So to have this kind of multi-stakeholder participatory engagement process, there has to be a quite serious effort from all parties involved to make room for each other, to accommodate each other and play to each other's strengths. And I think that the special initiative on mental health that WHO has instituted is one of the key catalysts for pulling these forces together. And we would like to see this kind of initiative spread much wider. What we also like to underline, I think, from our perspective, is that this kind of engagement needs to be. It's not a one size fits all. You need to listen. You need to have it locally designed, locally constituted based on the capacities and the special circumstances in each place. And I think that is again the model that the special initiative has. So we simply need to have national specialist knowledge. You have to have in Nepal or in Malawi national specialists who can be relevant to their own culture. So, and we should mention also some other practical things. We've only barely touched upon it, but things like telehealth is one of the solutions for actually affecting systems change. Telehealth as part of the health system is an opportunity for extending reach very, very much. So I want to wind up by simply, on behalf of the Norwegian Network for Global Mental Health, extending deep appreciation to all of you who have participated in making this happen. It is Harald Toru, Alison Schaefer, Michael Udedi, Paul Fife, Ksenia Semeniak, Kedar Marahata, Frode Forland, Nora Bråtu, but also Lisa Sivertsen, Marianne Moncler, Heidi Westberg-Stiel, Ragnhild Dybdahl. You are a wonderful crowd. Thank you for participating and thank you for making this a very good morning. Thank you.